Okay, guys, hey, this is Miss Bud, and I am going to go over some phlebotomy with you guys. I have some stuff to do with my students, so I thought maybe it would work if I just recorded what I would go over with y'all. So follow along with me in your book, page 209, for phlebotomy. So basically, the first couple things you always think about for phlebotomy is you want to verify your order and confirm your patient identity. You have to know what's ordered first so that you can even figure out what supplies you need, if there's any special preparation the patient needs, and then, of course, always identify your patient first. Also, you want to consider any pre-analytical factors, and that's just a fancy way of saying what should have been done or what should be done before we draw this patient's blood or before we take this sample. So for instance, sometimes a patient has to be fasting, which means they can have nothing to eat or drink by mouth for 8 hours prior to the lab work. So you want to, in fact, make sure that they're fasting. So that's an example of a pre-analytical factor, because if you find out that in fact the patient did not fast like they were supposed to, then that's going to affect the results, and you'll either not draw it that day, or even if you do and the doctor still wants it, then they'll at least know that the patient was not fasting. So you always want to consider those pre-analytical factors. Okay, yeah, you always want to question a patient first before they're going to have lab about if they've had lab before, which the answer is usually going to be yes, and if that's something that is makes them anxious, if they've ever passed out before. A patient should always be sitting or lying down when you draw labs. Don't ever draw labs on a patient that's standing up. In case they faint on you, they get really nervous and worked up sometimes, and they could absolutely faint or pass out on you. You're always going to want to explain the procedure to the patient, giving them just a basic overall of what you're going to do, making sure you get all your supplies, and there's a long list of the supplies you need on page 213. Making sure you have the right tubes, okay? And so if you look on page 214, there's the list of the order of draw. So order of draw, I know y'all studied, is that tubes must be drawn in a specific order. Otherwise, the additives in one tube can affect the results in another tube. So, for instance, a blood culture must always be drawn first, okay? But if you look on page 214, it's going to go over the order of the draw. It's yellow, light blue, red, tiger top, green, lavender, and gray. So you need to know that order, because you're probably going to get a test question that's something like, okay, you've got to draw, a lavender top, a green top, and a red top. What are you going to draw first? Okay. You also need to know the additives, and a couple of the additives that I would for sure know would be that yellow is for a blood culture, and the additive is called SPS. I would know that a light blue has sodium citrate. I would also know that lavender, the additive in the lavender tube is EDTA. Again, you really need to know all of those additives, but the ones I mentioned for sure. But that chart on page 214 you really need to study. Now, I want to add some things here to the chart on 214. So turn to that page, and you're going to write this in. So out by the light blue tube, I want you to write in where it says coagulation studies. I want you to write PT, comma PTT. This stands for prothrombin times, and partial prothrombin times. So, excuse me. But that is a very common study done in a light blue tube. Out by red, I want you to write type in RH, which is what we'll use when we want to type a person to see what type of blood they have. Skip on down to green. We use green tubes for these tests I'm going to mention are pretty popular. A BMP, which is a basic metabolic profile, a CMP, which is a complete metabolic profile, or a glucose, which is a blood sugar. Lavender tube, is very, very common. This is a very common question too, so you need to know it. A lavender tube, a common test for that is a CBC, complete blood count, CBC. And a gray tube, a common one that you might get a question about, is for a lactic acid. Lactic acid, okay? All right, so so all that to say that that's all part of your supplies. When you gather up all, you've double checked your order, you've made sure you've got the right patient, you have gathered your supplies, you've looked at your requisition already, your order, so you know what you need to draw, which means that you need to come and make sure that you have all the right tubes, and you need to make sure that you're going to draw them in the right order, okay? Then you're going to take a look at the patient, okay, to start to figure out, hey, exactly where am I going to go for this blood? What am I going to do? Age is always a factor, because if you have a kiddo that is from birth to 2 years old, they're going to always try to do a capillary sample. When we get blood drawn from our arm, like is what you traditionally think of, that's a venipuncture. That is accessing a vein and drawing blood from that vein. That is venous blood, okay? When we do a capillary sample is a finger stick. And a capillary sample is a mixture of both arterial and venous blood. And they will try always, as much as they can, on a baby up to the age of 2 to do a finger stick or capillary sample versus trying to draw blood from a vein, unless it's a very sick baby and you wouldn't be doing that. So highlight that somewhere, page 215, age determinants in the middle. You basically want to think about capillary samples for kids 2 and under. A capillary sample is going to be taken in a newborn. It's going to be taken from their heel. As the child got older, and you could, maybe 1 to 2 years of age, you can do a finger stick. But capillary samples are basically heel sticks or finger sticks, okay? Okay, so if you look on page 216, it shows you the anatomy of the veins in the arm. And I will tell you that those veins that are in the middle of the arm, in this space here, okay, this whole area right in here is called the antecubital space, right in here. So those are the veins that you want to use. The main vein that you're going to use is the median cubital vein. But really, any vein that is in that antecubital area, the cephalic or the basilic, are all good veins to use. The problem with the basilic vein, though, is there's a lot of nerves surrounding that, so that would not be my choice to go for. But hopefully you can get into the median cubital vein or the cephalic, or something that's there in that antecubital space. But on most patients, that's where we're going to go for. Okay, so you can do a hand, a wrist, or a foot if you have to. I wouldn't focus too much on that. You should be fine usually with finding something in the antecubital space. Okay, then once you can look and you can see where you want to go, you want to position the arm, and you always want to kind of have the arm coming down a little. That helps the blood is flowing down toward where you need it to go, versus if you hold the arm up, it's coming back up this way, which is not what you need. You want to clean the site, and so what you clean the site with most of the time is alcohol. Just an alcohol swab works to clean the skin really well, and you need to use a little bit of friction, because if you just barely tap it, it's not going to be clean. You want to use a little bit of friction. Now, the exception to this, and you need to write this in because I do not see it here, the exception to this is that when a patient has a blood culture, and remember, the blood culture is what would always be drawn first. When a patient has a blood culture, their skin has to be exceptionally clean. We don't want any bacteria off the skin in that vial, because they're actually growing it out to see what it grows. And if it grows something out, we want to know that the bacteria was in the patient's blood and not on their skin. So if you have to do a blood culture, alcohol alone is not sufficient. You need to use a betadine or iodine. Okay, It's the brown stuff you may be familiar with, but you want to use iodine. If the patient is allergic to iodine or shellfish, because if you're allergic to shellfish, you're usually allergic to iodine. If the patient is allergic to iodine, then you are going to use something called chlorhexidine gluconate. Chlorhexidine gluconate, CHLORHEXIDINE gluconate, GLUCONATE, chlorhexidine gluconate. I don't see that in your material, and maybe you won't have a question on it, but it is a question on the PCT test, and it is a very well-known fact about blood cultures. It's that you have to be really specific with those. So if you have a patient with a blood culture and you clean their skin with alcohol alone, that is not sufficient, okay? You need betadine, iodine, or if they're allergic, then you can use chlorhexidine gluconate, which is just a cleanser. Okay, then it goes on to talk a little bit about the different ways that you can draw blood from this vein, okay? The most common method is the evacuated tube method, which is probably what Ms. Bright showed you, where you are going to access the vein, and then you can change the tubes out because you have a little plastic, it's a double-ended needle. So basically, and it's encased in plastic, it's an adapter. And then that way you can access the patient's vein and fill up several tubes. Okay, that's the most common way. It's called an evacuated tube method. Another thing you can do is just draw the blood in a syringe, but that's not really the best way. So you really would rather use, because you can draw it up in a syringe, but you have to make sure you have enough, and then you have to make sure that you put it in the tubes in the proper order, and that's just basically where you use the needle and a syringe. The butterfly method is, hopefully she's shown you this, if not I can, but it's just usually a much smaller needle, like 25 to 26 gauge, and it has two little plastic things that you hold on the side. That's where the term butterfly comes from. So, but a butterfly needle is going to be for older patients or any patient who has small, fragile veins, okay? It's a smaller needle, and it has some thin tubing also that comes off of it. So it's the needle, and then there's a little bit of thin tubing that connects down to the adapter. What that does is that puts some space between the fragile veins and the suction. The suction on those tubes is really strong. So imagine if you have a vein that's the size of a straw, a regular straw, nice and hearty, nice and big. You can just draw that blood like normal, use the adapter, put the tube in, and you're good to go. Imagine then if you have an older patient or a younger patient who has veins that are really tiny, like a coffee stirrer. Okay, they're not big and fat like the straw, but they're much more narrow like the coffee stirrer. Well, when you put the pressure, when you insert that, if you do it traditionally and you insert that tube, that is a lot of pressure on that thin, tiny vein. And what do you think it's going to do? It's going to collapse it, and you're not going to get any blood. So with a butterfly needle, what you have is you have some tubing that runs down to the adapter that you then put the tube in, okay? And what that does is that puts some space between the small, fragile vein and all that pressure that's in that tube, okay? So that way it's not pulling with so much pressure and the vein does not collapse on you, okay? So you'll determine which method to use by looking at the patient and thinking about things like their age and, if they are a more fragile patient or not. You're going to then place the tourniquet. How long can we leave a tourniquet on? What's the maximum amount of time we can leave a tourniquet on? You need to know this coming and going because it will be on there. It's 1 minute, 60 seconds. It does not matter what happens. If you have a tourniquet on a patient, you cannot leave it on longer than a minute, okay? One of the big things it causes, and you need to write this down, it's on the bottom of page 218, you need to know this. And you need to know another term that students often get confused, okay? So if you okay, the term I'm fixing to tell you about the tourniquet is called hemoconcentration. So hemoconcentration, if I leave a tourniquet on longer than a minute, then that specimen can be what's called hemoconcentrated or hemoconcentration. It is not on the bottom of 218. It is It's on the bottom of 211, okay? So hemoconcentration is caused by leaving a tourniquet on too long. And what it does is it causes the red blood cells in the sample to be super concentrated in the sample, which means you're not going to get accurate results, okay? So leaving a tourniquet on too long causes hemoconcentration, which is an increased concentration of red blood cells in the sample, okay? It's going to give abnormal results. The word that students often get it confused with is something called hemolysis or hemolysis, and that is on the bottom of page 218. Hemolysis is basically, simple and basic, is just the destruction of red blood cells. The number one way that happens is by shaking tubes, not keeping them upright and really aggressively shaking them. When we draw tubes, we just gently invert them. If you shake them like that, you're going to break down those red blood cells, and that's called hemolysis or hemolysis. Another thing that causes hemolysis is when you use too small of a needle. So you always want to use the size needle that you need, that's necessary. You don't want to go really big and do like a 16, but you also may not, if you're drawing a lot of blood on a patient, you may not want to do a 26 or 28 gauge, okay? So, but you need to know those terms, hemoconcentration versus hemolysis. What I tell my students, they have a hard time remembering them both, so remember one. So for instance, if you can remember backwards and forwards that hemoconcentration is an increase in the concentration of red blood cells in the sample that is caused by leaving a tourniquet on too long, then remember that. Great if you can remember hemolysis too. But if you can't, at least make sure you know one of them coming and going, and you won't get them confused, because students often get them confused on the test. Okay, so you apply the tourniquet. Don't leave on longer than a minute. When you go to actually draw the blood, you're always going to have the needle with the bevel up. The bevel is the slanted part of the needle, and you always want it bevel up, okay? And you're going to make a smooth, quick motion actually when you do this. Do not, you can imagine how it feels for the patient if you like go in really gently and no, it hurts. You want to make a smooth, quick motion once you've found the vein that you want to go into, okay? And then you'll use your tube system or whatever you're using. Okay, if you look on page 221, it talks about a capillary sample. Again, a capillary sample is a mixture of venous blood and arterial blood, and it's often used when we just need a small amount of blood. It's used on kids and babies up to the age of 2, and it's heel sticks and finger sticks. We also use it on adults all the time to perform some simple tests like blood sugar or even cholesterol testing. There's quite a few things you can do with just a simple finger stick. So if you look on page 222, what I want you to see there is it's showing you where we do finger sticks and heel sticks, okay? Meaning I'm never going to go in the middle of a baby's heel. I'm going to go out to the side. I'm never going to go down lower on the finger. I'm going to go toward the outside, left or right. Also with fingers, you're going to use the middle 2 fingers are your best bet. So your 3rd and 4th finger are your best bet for doing a finger stick. So now, when you do a finger stick, what we often have a tendency to do when we first start doing them is you clean the skin. Whether it's a finger or a heel, you say it's a finger. So you stick it, and then you squeeze. Okay, well, that's fine if you get enough blood from that one squeeze. But if you don't and you need more, one of the biggest things people do is they have a tendency to just keep squeezing. That will not give you any more blood. Let go, okay? And let go and let the finger fill with blood again, and then gently squeeze, okay? Let go, let it fill, and gently squeeze. You don't want to milk the finger where you just like constantly rub it like this, or you just constantly squeeze it. That's not going to help you. You've got to allow time for the blood to fill back into the area that you're trying to collect from, okay? And then anytime we finish up with the patient, you want to, of course, use some gauze or something and just apply pressure. You want to pull the needle out and then apply pressure. Oftentimes you see people doing this, and they have their gauze down there on top of the needle, so it looks like they're holding pressure before they pull the needle out. That causes a hematoma, which is a big bruise on the patient. Don't do that. Just make sure that you have it there and you're ready to go, but you actually don't. You pull the needle out gently and then apply pressure. Okay, so don't apply pressure with that needle still in the arm. Okay. Sometimes you will have to put samples in what's called a centrifuge machine. A centrifuge machine is, and I'll try to get you a picture of it, but we have some here. But basically, it's a machine that is going to spin the tubes for a set amount of time, and it's going to separate the plasma from the serum in the blood. And certain tests have to be done this way. But in a centrifuge, what you want to remember is that there must be balance. So it's round. So if I have 3 tubes on this side, or let's say I have 2 tubes on this side, let's just say the whole thing will hold 8 tubes, okay? So I'm going to balance that by putting the 2 tubes across from each other. If I have 3 tubes, I'm going to put 2 across from each other, 1 here, and an empty tube across from this one, okay? Meaning it has to be balanced. You turn lock it down, turn the centrifuge on, it will spin, and then when you take the sample out, you can see where the parts of the blood are actually separated, okay? You always want to make sure that you label specimens immediately after they're drawn. It's just like we don't chart things before we do it. We don't label all of our specimens before we've drawn the blood. You have your labels with you, but you want to make absolutely sure that you label them in front of the patient immediately when you are done drawing the blood. Do not stick them in your pocket and walk out of that room. Do not label them first and then go in and get called to another room and actually use those tubes to label for someone else's blood draw. So the bottom line is, with labeling, you always want to label the specimen in front of the patient as soon as you're done collecting it, okay? Those are pretty much the highlights, guys, from phlebotomy. If you have any questions about things I talked about here, write them down. And I will see you probably on Wednesday of this week, so we can talk about it on Wednesday. So I want you to look over this material. I can't remember, this is chapter 12, which I do not think I have assigned. So you're going to watch this video, look over the material, be in the study guide a little bit, and I'm going to have you take this quiz, okay? So again, write down any questions you have about anything that I've said. We can talk about it again when we're together. Okay? Thanks, guys. Bye.